go ahead and introduce our speaker. Dr. Danielle Anderson received her medical degree from the University of South Carolina School of Medicine in Columbia, South Carolina. She completed her family medicine residency in the University of Kentucky Rural Track, spending her last 2 years of residency at St. Clair Healthcare in Moorhead, Kentucky. She is board certified family medicine physician. She completed her addiction medicine fellowship in the Department of Psychiatry at the University of Kentucky, where she now works as an assistant professor and works full-time as an addiction specialist. Welcome back, Dr. Anderson.
So, hi everybody. It's good to see you all again this week. Have no relevant financial relationships to disclose. And here are our practice gaps if you want to scan through those for a minute. And they'll also be available on the slide handout on the KY Open website, I believe. And so our learning objectives, same as last time, we're going to identify the common stimulants, talk about pharmacological action and current trends in stimulant use. We're going to talk about the impact of co-occurring stimulant use and opioid use, and then explain treatment options for stimulant use. And here's a little bit of a recap on our presentation from last week. Outline talk, again, we're talking about stimulant types, acute intoxication and withdrawal, and the trends in stimulant use, and also the treatment of stimulant use disorder. And here are examples of commonly known stimulants. Again, Schedule 1 drugs have no legal medicinal use in the U.S. and also have a high potential for developing psychological dependence or substance use disorder. Schedule 2, again, cocaine, methamphetamine are common ones we've seen there that have, both of those have limited medical use. We don't often really talk about that. And then you have your also in Schedule 2, still some risk for psychological and physiological dependence with these, but our treatments for substance use or treatments for ADHD, amphetamine salts, methylphenidate, and lisdexamfetamine. Schedule 4 Schedules 3 and 4 common ones are modafinil, Provigil, phentermine, which is the common medication that Adipex that people use for weight loss, and then pseudoephedrine, which you're going to find in nasal decongestants over the can be purchased over the counter. In Kentucky, you do have to show a license. And then over the counter phenylephrine, again, nasal decongestant, but not one you typically have to show your license to be able to purchase. And reviewing this slide of relative dopamine release, dopamine is the main neurotransmitter or brain chemical that's involved with stimulant use. And want to remind you that dopamine release is a natural and normal process in the brain and the body. And so we get this dopamine release from normal activities such as food, video games, sex. This is what I like to call the carb coma for food, when you have that kind of relaxation and calmness after you eat a heavy carb meal. That's probably related to dopamine release. And then we see that cocaine, amphetamine, and methamphetamine really ramp this up much higher than our normal dopamine levels. And reviewing acute stimulant intoxication and then medical effects and complications. So when someone is acutely intoxicated with stimulants, we may see that their pupils are dilated. They may be hyperventilating, tachycardia, high heart rate, elevated blood pressure. They may have chest pain, they may be agitated, have headache, develop psychosis, delusions, or hallucinations. Other life-threatening complications that can occur from methamphetamine use are seizure, cardiac arrhythmia, so abnormal arrhythmias, multiple abnormal arrhythmias that can occur here, hypertensive emergency where the blood pressure is so high that it can cause damage to tissues, myocardial ischemia or infarction, heart attack, cerebral ischemia, where we have decreased blood flow to the brain, malignant hyperthermia, where our temperature gets so high that we're unable to bring it down. And then we have a question later about rhabdomyolysis that we'll talk about, pulmonary edema, and acute asthma exacerbation. And just a reminder that there's no stimulant reversal agent. Some of our stimulant use trends, we talked about the binge and crash pattern of use is popular, where people will use and use and use for days and days and days, and then have a crash period where they're very tired, fatigued, have very low mood, and that can last several days to a week. There's the use of methamphetamine plus cocaine, use of methamphetamine or cocaine plus opioids. This is known as speedballing. We know that overdose deaths involving stimulants are on the rise, and often the methamphetamines are used with substances like substances such as fentanyl or fentanyl analogs. And we know that during the pandemic, by 2020, all substance use had increased by 13.3%. And I'm sure if we were to look at some data of the years following after that, we would probably see a similar trend. Some more stimulant use trends. So in 2020, 2.5 million people ages 12 and over reported methamphetamine use, and 53% of those met criteria for stimulant use disorder. However, only 1 in 3 received any treatment. And then the treatment of stimulant use disorders, as I hope you all took away that this is actually very complicated. There aren't any FDA approved medications to treat stimulant use disorder to date, and that's mainly that no medication has been shown across the board to be very, very helpful. And that's really unfortunate, but it is an area that is being continually studied in the research. Treatment's individualized for stimulant use disorder, and it requires a comprehensive assessment. There's going to be patient-specific treatment plans, and all treatment for substance use disorders should be patient-specific. I just want to add that in there. What we know from researching all substance use disorders is that it's not a one-size-fits-all. NIDA also asks us to do patient-specific treatment plans. It really works. People have the most success when the patient and the provider or the therapist have a mutual goal that they both agree on. So for stimulant use disorder, patient-specific treatment plans may include off-label use of prescription medications, psychosocial interventions such as counseling and behavioral interventions, and then also harm reduction and overdose prevention. Our behavioral interventions that we talked about, these are the ones that have proven to be effective after years and years of study. Contingency management, that's that behavioral intervention designed to promote desired behaviors by providing positive reinforcers such as rewards. And we give those when the target behavior occurs. So an example again is patient where our desired goal is for the patient to have negative urine drug screens for methamphetamine. When they achieve that goal, they get some sort of reward, some voucher, positive reinforcement for doing this. And then the other one we talked about, which is a little more involved, is the community reinforcement. And this is behavioral intervention that focuses on the management of substance-related behaviors and helping patients create and adopt more pleasurable and rewarding lifestyle. And these lifestyles, we want to really kind of ramp up time spent with family, friends, getting a meaningful job. And hopefully what happens is that these lifestyles that involve family, friends, job, and positive reinforcing activities become more rewarding than the actual use of substance. We always want to include harm reduction and overdose prevention in any plan to treat a substance use disorder. And so we have this opportunity when we identify or somebody seeks treatment for a stimulant use disorder, screening to identify the disease in its earliest stages. So want to screen all of our patients that are coming in, even for opioid use disorder or other substance use disorders, for a stimulant use disorder. Maybe we can identify that before the stimulant use disorder gets worse. This is also an opportunity for primary prevention, which we may be able to prevent another substance use disorder or the sequelae of a substance use disorder, such as endocarditis or developing a bacteremia or life-threatening condition from use. And it's also an opportunity for tertiary prevention. And this is managing the disease after diagnosis. So an example of this could be identifying hepatitis C in somebody that has a stimulant use disorder to prevent the progression to cirrhosis or cancer. So in summary, our stimulant use disorders are very difficult to treat. They involve off-label use of prescriptions, behavioral interventions, and harm reduction. The community reinforcement approach and contingency management approach are effective evidence-based behavioral interventions for stimulant use. And we need to develop more programs that involve both of these, because this is what the research tells us is the most effective at treating our stimulant use disorders. And I'm not sure if we have any questions, just going to check on the chat here. Please feel free to submit questions to the chat, and I think John and maybe Devin are on here, and if you notice some question that I don't notice, please feel free to stop me. A case study with everybody, and just get your take based on what we've talked about. This is a patient of mine that was a 28-year-old male that had a history of generalized anxiety disorder and major depressive disorder, and that presented to the office stating, I want to stop using meth. He had been using methamphetamine IV for 5 years, and 2 months ago, he received a new diagnosis of HIV. He was started on HIV, but missed his follow-ups with infectious disease. And since his diagnosis, he's reduced his methamphetamine use daily, from daily to 2 to 3 times per week, due to concern that he's going to get more ill. He was prescribed mirtazapine to help with sleep by another physician, but this made him feel crazy. He is currently on bupropion, which is Wellbutrin, 300 milligrams, and feels this has helped with depression. He reports that he is currently sexually active and is polyamorous. Does anybody want to type into the chat or feel free to unmute yourself about what additional history we might want to know from this patient? Other substance use, yes, that's a great one. We want to take this opportunity to say, hey, if we have an opioid use disorder that needs treatment, or nicotine use, or anything that we can talk about, we want to take that opportunity. Number of sexual partners, that's definitely important. We know we have this diagnosis of HIV, so we want to take the opportunity to maybe encourage this patient to get on his antiretroviral therapy, do some education there, education about safer sex practices such as condom use, and then does he have any barriers to getting to an infectious disease doctor? That's great, Kimmy. Oftentimes patients are embarrassed about their inability to have a ride or a way to get to treatment, and we definitely don't want that to be a barrier. And Megan, you're absolutely right. We want to know, is this person practicing safe sex, and how can we how can we facilitate safer sex practices? Next question, based on what we talked about, is there any treatment that you would recommend for this patient to treat his stimulant use disorder? I do see Christy wrote, curious, as a retired special education teacher, I noticed these were commonly prescribed medications to youth. Is there research being done to follow up with potential short or long-term medical and mental effects, possibly along with that age bracket? Are you talking, Christy, are you talking about stimulants that are used as prescription medications, or are we talking about mirtazapine and the bupropion talked about in this case?
The stimulants like the Adderall, Vyvanse, Concerta, Dexedrine, all of those.
Absolutely. Absolutely. That's a great question. I'm going to answer some of that in the case study or in the questions following. But what I can tell you is there is a recent study that came out that looked at long-term health effects, specifically cardiac effects of stimulant use for people who are prescribed prescription stimulants. And in terms of cardiac concerns, there was really no difference between the general population and those who had used prescription stimulants, used properly and appropriately, not misused. But I think there are several studies that are following this, especially as we're going to talk about coming up with the number of people who are misusing stimulants.
So Danielle, I would just add, there is some pretty solid data to suggest in cohort studies that untreated ADHD represents a greater risk factor for the development of substance use disorders in the future than the stimulant therapy for ADHD. Right. So it's much more of a concern that we have youth that are undertreated or untreated for ADHD than the stimulant therapy that we are using itself. That's where the literature currently is at.
Absolutely. And we'll talk a little bit about that in the following questions. For this patient, we know this patient's already on bupropion or Wellbutrin. I think some of us recognize that as Wellbutrin. A possibility for this could be the use of the intramuscular naltrexone along with the bupropion, which is IM naltrexone. I think somebody had asked in the last lecture about that. It's the IM naltrexone is actually Vivitrol, so that might be a possibility. Mirtazapine has been shown to have a modest benefit in reducing cravings, but for this patient, it's possible we could add the intramuscular naltrexone and use that. And then the other opportunities for primary, secondary, and tertiary prevention, I think we talked about that. Somebody mentioned screening for other substance use disorders, which is a great idea. Also, discussing safer sex practices, preventing the transmission of HIV, prevention of further infectious disease for this patient who is now immunocompromised. Any other questions or comments there? I'm having trouble advancing the slide. Okay. And we're going to move on to some questions. You all submitted some great questions. So are there certain populations that are at higher risk of stimulant use? Yes, yes, the short answer is yes. And SAMHSA released an advisory on prescription stimulant misuse and prevention in youth and young adults in 2021. And here's some epidemiological numbers. I actually, when I was looking at this, thought they might be a little bit higher. But so our highest use age group is from 18 to 25. But going back to what you were talking about, Christy, our prescription stimulant use and misuse among ages 12 to 17. And I just wanted to stop for a second and discuss misuse. So prescription use would be using the prescription exactly as prescribed. When we talk about prescription misuse, that's going to be any deviation from how the physician prescribed this medication for the patient. So that could be taking too much, that could be using intranasally instead of orally. Those are examples of prescription misuse. So in 2019, 7.5% of youth reported use of prescription stimulants in the past year, and 1.7% of those youth reported the misuse of stimulants in the past year, and about 0.3% of those had a stimulant use disorder. Looking at this a little bit differently, 23% of youth who had 23.4% of youth who had any prescription stimulants in the last year misused them. And amphetamine type stimulants, which are often the ones that are prescribed, were reported, most commonly reported used among 8th, 10th, and 12th graders. So for the population of 18 to 25, which is where most of our stimulant users are in 2019, 12.8% of adults reported the use of a prescription stimulant in the last year, and 5.8% of young adults reported the misuse. 0.6% of those adults had a prescription stimulant use disorder in the last year. 45.2% of those young adults who used prescription stimulants in the last year misused them. So that's a much higher proportion than in the 12 to 17 range. And young adults who attended college are more likely to misuse prescription stimulants when compared to their non-college peers. And I think someone brought that up in one of the next questions. And here are some risk factors. I just wanted to take some time. I think this is a great chart listed in SAMHSA's advisory on prescription stimulants. And I do want to add the caveat that Devin, that Dr. Oler mentioned, is that one of the risk factors really for stimulant use is untreated ADHD, and provider bias oftentimes leads to the undertreatment of ADHD. There are a lot of providers who are concerned about exactly what Christy mentioned, that that these prescriptions are going to be misused, or that people are going to develop a use disorder. But in fact, for those who have ADHD, this makes them less likely to develop a substance use disorder. So risk factors for prescription stimulant misuse at the individual level, what we see are patients ages 8 to 25 who are white, they're older or higher grade level. And again, diagnosis of ADHD is there. But like Dr. Oler mentioned, again, these people are actually less likely to develop stimulant use disorder when treated appropriately. History of household or family members as a source of prescription stimulants, friends as a source of prescription stimulants, and then there's this pressure in the academic environment. Prescription drug misuse and prescription stimulant misuse. At the individual level, we see mental health comorbidities like depression. There's motivation for misuse, poor academic performance, and engaging in other risk behaviors. We see another risk factor with family and relationships or lack of parental support, negative parental attitudes, and substance use by family members, which I think we see a lot. And then just a few in community and peers. We see this is more common in patients who have peers that are misusing. So again, I'll send this out, but I think this is a great chart to really kind of assess, be able to look at patients with substance use disorders and go through and assess if any of these risk factors are present. I have heard there is a trend. This is another question submitted. I've heard there's a trend of stimulant misuse with younger people to help with studying. Is this a trend? What would be the warning signs for stimulant use disorder for this group? I think we talked a little bit about the fact that that age range 18 to 25 in college are more likely to misuse prescription stimulants than their non-college peers. So we're going to talk a little bit about what it might look like for someone who is using stimulants. And we need to know that there are short-term effects of prescription stimulant use. Increased blood pressure, increased heart rate, increased breathing rate, decreased blood flow, increased wakefulness, hyperactivity, or a state of euphoria. These can all happen with short-term prescription stimulant use. And it does sometimes it takes the provider a little bit of time when prescribing these to find the correct dose, because over prescribing or prescribing too much can result in more severe effects. But when we think of youth and substance use disorder, we typically talk about signs of a substance use disorder in youth population. A lot of times they isolate themselves. There's a change in mood. There's a decrease in academic performance, change in friend groups. And so that's what we typically do when look for when we're screening youth for substance use disorders. However, it might be a little more difficult if you have a youth or a young adult who is just misusing stimulants or getting them for studying purposes. But I think it's important that if you are concerned that we discuss the short-term effects when these are taken at high doses and the long-term effects of prescription stimulant use. Another important point is that many youth and even young adults that I talk to think that because a stimulant is a prescription that it's safe, and it's not necessarily safe for every single person to take take a stimulant. So prescription drug does not equal safe for all people. The short-term effects of prescription stimulant use when we're taken at high doses can be dangerous increase in body temperature, irregular heartbeat, and seizure. And then long-term effects of prescription stimulant misuse are heart failure and adverse cardiac effects. And these typically occur at doses higher than what's prescribed. Psychosis with behaviors that are similar to those of schizophrenia. So patients may hallucinate or they may have delusions. And this long-term prescription misuse may lead to a stimulant use disorder or other substance use disorder. How does methamphetamine use cause rhabdomyolysis? So this question was submitted. Someone close to me had a non-fatal overdose from illicit fentanyl and methamphetamine use, and doctors found out from this that they also had rhabdo. I have never heard of this, and they said it may be from methamphetamine, but offered no explanation. Stimulant use and rhabdomyolysis. So rhabdomyolysis, and I'll call it rhabdo so we don't have to repeat that long word so many times, is the breakdown of muscle tissue when muscles are overused. And what typically happens is muscles break down and deposit some of the protein into the urine, and this can be very dangerous. It can cause kidney problems. People with rhabdo can get very, very sick. And common causes of rhabdo are hypothermia and muscle overexertion. With stimulants, one of the main side effects of stimulant overuse can be hypothermia. And there is the possibility that muscle exertion could also contribute to this. If we think of somebody that's using a lot of stimulants or binge or in the binging pattern, they may not have time to relax. They may not have time to, they may just be, going and going and going and not, and maybe overusing muscles a little bit. So in the literature, this has been noted that there is this association between stimulant use, particularly methamphetamine. And so proposed mechanism is a little bit of both of these, the hypothermia and the muscle overexertion. And also while a person is using, they may not notice how sick they're becoming. There are other drugs that are associated with rhabdo. Stimulants, MDMA, which is ecstasy, and PCP are also common. Can naloxone still be used if someone is using multiple substances? If someone is using a stimulant, cocaine or methamphetamine that may have fentanyl and is showing signs of an overdose, is it safe to use naloxone? So let's review what stimulants and opioids do in the body. So stimulants are going to cause decreased blood flow to the brain, and then loss of thermoregulation, like we talked about, hypothermia, inability to cool the body down, stroke, and seizures. In the heart, we're going to have increased heart rate, high blood pressure, possible heart attack, and cardiovascular collapse. We may see in the lungs, we may see an exacerbation of asthma, pulmonary edema, or hemorrhage, and we could also see acute renal failure. For opioids, their effect in the brain is CNS depression. We may see altered consciousness or respiratory depression. We're also going to see decreased cardiac output, possible cardiovascular collapse, and respiratory depression in the lungs. We're also in an opioid overdose. The three things we talked about are altered mental status, pinpoint pupils, and respiratory depression as sign of an opioid overdose. So is it safe to use naloxone? Yes, but when multiple substances are involved in an overdose, that's a more complicated resuscitation. So we want to make sure that we call 911 right away. This is becoming increasingly common because there's a lack of pure stimulants on the street, or stimulants that most of them are containing other substances. I've seen patients come in with the stimulants who have also contained benzodiazepines, or have also contained, like we talked about last week, fentanyl or fentanyl analogs. Naloxone will reverse the respiratory depression if it's caused by the stimulant, or if it's caused, by the opioid, but it's not going to do much for the stimulant effects that we just talked about. And again, most important thing when you're starting is call 911, get 911 on the phone as soon as possible, and they may provide additional guidance while you're waiting for EMS to get there. What is the safest way to manage a dual diagnosis of ADHD or ADHD and OUD? A participant is anxious regarding a discussion with their doctors regarding treatments for ADHD and OUD. What medications can a participant be prescribed for both their ADHD and MOUD? May the participant take the stimulant-based medication while using buprenorphine, naloxone, or methadone? So comorbid stimulant use in ADHD may be treated with stimulant use medications such as Adderall or Vyvanse, amphetamine, dextroamphetamine, lisdexamphetamine, or non-stimulant medications such as Strattera. We want to consider extended release medications like Dr. Oler mentioned, persons with ADHD plus substance use disorders are not more likely to abuse prescription stimulants. Persons with ADHD are more likely to develop substance use disorders during lifetime, but may be related more to anxiety and depression than the actual ADHD. So again, it's really, really important to identify patients who have ADHD and treat them with appropriate prescription medications and behavioral interventions. The other thing to know is that the KRS regulations, the state regulations state that if a patient is going to be on buprenorphine or another controlled substance, buprenorphine or benzodiazepines, and they're also prescribed stimulants, that there needs to be consult with an addiction specialist who's board certified by the American Board of Preventive Medicine or a psychiatrist. So those consultations are important to obtain, and that's just part of the state regulation. Psychostimulants to treat stimulant use disorder. Just as we've seen, this is another question, just as we've seen clinics opening in the US that use ketamine off-label for treating mood disorders, do you foresee clinics opening that use psychostimulants in the treatment of stimulant use disorder? So yes, in theory, psychostimulants could work to reduce cravings and prevent withdrawal. The two that have been studied for this are dextroamphetamine and extended release methamphetamine with cocaine use, but there's been little efficacy demonstrated. And there's also, concern about provider bias that we talked about. And I don't think it's that providers don't want to treat patients appropriately. I think they are concerned that they may contribute to or make a stimulant use disorder worse. So what we need is probably some more research in this area. Are there any issues with a person using over-the-counter stimulants if they have OUD or on MOUD? So, in general, there's really no there's no precautions. It's just general health precautions. Nasal decongestants like pseudoephedrine or phenylephrine may cause an increase in blood pressure. So if you have a patient that's being treated for high blood pressure, generally we want to avoid this. Weight loss prescription stimulants such as Adipex suppress the appetite. They're typically prescribed for weight loss. And then there's over-the-counter stimulants. In the past, there was one called Fen-Phen. And, it's something that we need to watch out for new stimulants on the market because the side effects of stimulants it may not be so much that there's a problem with the MOUD. It may be other medical problems such as arrhythmias or hypertension, or some of these can cause anxiety or increased heart rate. What is the best way to treat depression in people with stimulant use disorder? Is this complicated with co-occurring opioid use disorder? So we talked about the acute effects of stimulants in the brain. Cocaine works by blocking dopamine reuptake. So we have this longer time for cocaine to interact with the receptors and cause all of the effects that we know are caused by cocaine use. And then methamphetamine works a little differently. It causes like a dopamine dump, like extra dopamine in that extra dopamine release that can interact with the receptors. And again, you know, like we saw in the chart, sometimes up to 1,000% more dopamine than with normal activities. This leads to more dopamine interacting with the receptors, resulting in all of the effects we talked about for stimulant intoxication. So treating depression in patients with stimulant use disorder, it can be harder to treat. When stimulants are used, when stimulants are constantly used, we get kind of this over exercising of our dopamine and our dopamine transport systems. And then when we have normal processes that use dopamine in the body, it's mood regulation, food, you know, things that are pleasurable, things that make us happy. It's like pouring from an empty watering can. So it's like pouring from an empty glass. We've used all this dopamine when we were abusing our stimulants. And so when the body's trying to do regular functions, we don't have a whole lot of dopamine right after that. As time goes on, our dopamine and dopamine transporter systems replete, but there could be a period, sometimes up to several months, up to a year, where we just don't have as much dopamine as we did in the past. And so mood regulation can be affected. And that's why one of the things we want to do is set expectations about what's going to happen when we take medications. We want to use our typical medications for SSRIs, SNRIs, so our medications like fluoxetine, duloxetine, bupropion can be used, which is Wellbutrin, and mirtazapine. But again, we want to try and set that expectation that mood may improve over time, but we've depleted a lot of our dopamine system, and so it can be hard to regulate mood initially. What resources or handouts are available to give clients and patients about stimulant use disorder? Here are a couple that I really like. There's one from Yale Medicine, and again, John will send this out, and another one from drugabuse.gov that can give us information that we can provide to patients about stimulant use disorder. What recommendations do you have for clients that have severe cravings for stimulants? Problem: client is having severe cravings for stimulants. They have stopped using opioids with their MOUD. They haven't found anything else that helps with their cravings, no matter what behavioral changes they have tried. They have heard some medications for ADHD may help with this, though. They have also not had any negative consequences from their stimulant use that they can see, only that it is causing issues with their MOUD doctor. Perspective: I want to send them to a doctor that may be able to help them with medication if at all possible. Purpose: if client is still struggling with the use of stimulants and not having any other negative consequences other than the MOUD provider threatening to kick them out, what do we do? So in treating stimulant use disorder with stimulants, again, there's limited research, but recommending motivational interviewing, cognitive behavioral therapy to understand the cravings. We also want to use motivational interviewing to help the patient understand negative consequences of use. And then we can try other drugs with some efficacy, like mirtazapine and the Wellbutrin. Sorry, that should be naltrexone, not naloxone. So the Vivitrol plus Wellbutrin. There's really lack of evidence to do this at this time. And then again, we run into the provider bias. If this patient has ADHD, again, that may be an indication to treat the ADHD with stimulants, but not necessarily stimulant use disorder. And then another point I wanted to make is that there's been some recognition, SAMHSA and NIDA, of this new problem where people are having stimulant use and opioid use disorder, as we've talked about, this rising epidemic. From a clinical perspective, if someone has an opioid use disorder that is well managed with buprenorphine or Suboxone, and they also have a stimulant use disorder, there's not really an indication to stop the buprenorphine. We don't want to stop treating one disorder because someone has another disorder. We want to find a way to treat the stimulant use disorder. And in this case, if the provider is absolutely against providing Suboxone while the person is or buprenorphine while the person is still using stimulants, it's something that we're working on. May need to find a provider who is willing to work with the patient on both the stimulant use disorder and the opioid use disorder. It's difficult though. It's a difficult topic. I mean, it's a difficult conundrum that I think a lot of providers are facing right now, because we don't want to harm the patient. We want to do what's best for the patient, but there are significant concerns about stimulant use. But it would be more dangerous for the person to use stimulants, to use heroin and stimulants than us treating the opioid use disorder plus the stimulant use disorder. And I think that's all I have for today. Does anybody have any additional questions or any questions about what we've talked about, or any comments, Devin?
I actually got a couple of questions sent to me through direct message.
Okay.
First was, how often does stimulant-related psychosis occur?
You know, I don't have epidemiological data on that, but it typically occurs at doses that are much higher. If we're talking about prescription stimulant induced psychosis, usually happens at doses that are much higher than what people are prescribed on a daily basis. I can look into that, but it happens, I think it occurs most frequently, where we see it most frequently is in the emergency departments when people start developing psychosis or delusions and someone brings them in to get help.
Yeah, I would say it's definitely more often with non-prescribed stimulants like meth. The really scary thing is that while many times it will resolve within a few days after removal of that exposure, some symptoms can persist for weeks afterwards. And I think sometimes folks who are using daily high-dose meth run into, if not frank psychosis issues, then a lot of paranoia, and that can be difficult to sort of work through with a client, sort of trust issues and other concerns. If they're dealing with that significant paranoia and anxiety, even sort of sitting down to talk with them and trying to meet them where they are can be a major struggle. So I often will try to work with the clients to see if we can't create some pauses between use, or schedule appointments around times when they know that they might not be using, to try to better meet their needs. And Matt is mentioning in the hospital, like seeing it pretty frequently in patients who are using methamphetamines as well. So it's a major barrier to getting effective care often.
It is. And I have noticed in my clinic that sometimes that is the event that pushes patients to getting into treatment, how scary that psychosis and paranoia can become. And once it resolves, they're afraid to go back to using. I did have a patient in the last couple of years who developed some paranoid delusions that someone was out to get his family, and that he was either going to have to self-harm, or the people out to get his father were going to kill his father. And so he chose to self-harm. It was very, very scary. It persisted for several days, and he did end up in the hospital after the self-harm. So it can be very extreme. And it's very scary and very miserable for the person going through it.
Thanks for that response. And then I had one more question. I've heard about stimulants being used to augment sexual experiences. I believe it's called chemsex. How do you approach patients engaging in chemsex?
Yeah, I've had several patients come in, and it's thought that methamphetamine can enhance sexual activity. It's typically been used, studied most in the population of men who have sex with men. But it's really hard because a lot of times people who use this for chemsex are not daily users. It's intermittent use. And so sometimes they don't see all of the negative effects of stimulant use. So I have a very frank discussion about all of the risks of stimulant use and stimulant overdose, because it's a lot of these things, there's a lot of information out there for patients who want to know information about opioids, but you have to dig a little more to get the stimulant use. So, we want to sit down, we want to have an honest discussion and hear exactly why they're using, what it's helping, what it's helping the patient with, get them some, in to see a therapist and some counseling. And then again, really going over the health effects that even stimulant use one time, can cause an overdose. Anything to add, Devin?
Yeah, I think the trying to understand if there's significant sort of medical issues going on with sexual performance is important too, right? Are they sort of self-treating issues of erectile dysfunction or low libido or other things that might be better addressed through evidence-based treatments? But I think you bring up a really good point, Danielle, which is oftentimes folks will delay or downplay sort of their stimulant use, in part because it's perceived as less concerning than sort of opioid use or even sometimes alcohol use. And it's a useful reminder that you can meet criteria for a substance use disorder without daily use, right? And in fact, sometimes binge use is higher risk than daily use for some substances, including stimulants, where sort of that sudden stress to the system or can cause significant cardiovascular injury, stroke, heart attack, those sort of things. And I think we're also seeing that use continues into an older population with more medical issues going on. And that can be a major driver to see why there's more fatal overdoses from stimulants as well. So I think keeping in mind when you're seeing clients, taking that non-judgmental approach and providing some education about the significant risks of stimulants, but understanding the why first can be our guide to finding the right treatment options for them.
Great, thank you for that response. I think that concludes the questions that were sent to me, but we do have time left, so I will open the floor to see if anyone else has a question. You can use the raise your hand feature, you can come off mute, or like other people have, you can send me a direct message and I'm happy to ask a question on your behalf.
And I'd be interested to hear if folks have stories of success, of people doing well and recovering from stimulant use, because I think it can be pretty just demoralizing from the clinician side of things to see people struggle with this and not having great options for them. But I'd love to hear if folks have some positive or success stories that they'd like to share.
I do have a couple patients that have been successful, and one of the patient has really leaned on the crystal meth anonymous groups that are out there. I think there's a local one through Voices of Hope, and a couple of them have cited that sometimes they can't identify with people who are using substances that are typically depressants, such as opioids and alcohol. And so having this crystal meth anonymous group where other people who were experiencing the exact same issues, including the depression, that's pretty bad. She cited depression as one of the major triggers for her to continue use. But at some point, the use had been had been going on daily for almost a month, and she was so depressed she decided to go into medically supervised withdrawal. And again, as we talked about, there's not a lot of great information, but it took her getting out of that environment where she couldn't use. She was in a place where she could get sleep, where she had food, she had water, she had all of the things that she needed, she had the support that really helped her jumpstart getting into sobriety. But just a reminder that there are specific crystal meth or methamphetamine stimulant groups out there that people can get involved with.
Dr. Devin, I do have a 32-year-old son that during his secondary years of school, he had an ADHD diagnosis. And he was actually on Adderall, and I think maybe at one point Vyvanse, but in his college years, he didn't need them, and he's a productive working adult and hasn't had to use any type of medications or illicit street drugs. So I guess that's why I was surprised when I saw that, because it was effective for him during, like I said, his elementary and middle school years. And, he's doing well, doing fine, thriving.
Yeah, it brings up the point that we really need more data on adult ADHD and sort of best practices for treatment and what outcomes are there to be expected. And I think it's a good topic potentially for a separate KY Open session as well, because I think we run into a lot of those issues with concentration, attention in our patients coming in for treatment of opioid use disorder and other substance use disorders. So thank you for sharing that, and I'm so glad that he's doing better.
And Christy, about 40% of patients that are treated as children end up not needing stimulants as an adult. It might be a little bit of a conservative number, but some of the symptoms resolve. And then there are other times we learn behavioral mechanisms to deal with the symptoms of ADHD. And so sometimes stimulants aren't needed.